All right, this is Dr. Purcell. Let's do 10 slides of heparin in 10 minutes or less. If you remember, heparin is an anticoagulant. Never, ever is it a blood thinner. It doesn't do anything to thin your blood. It keeps your blood from clotting. It's called unfractionated heparin. It's a relatively large molecule. Believe it or not, it's derived from animal sources, a porcine source. And we use the lab activated partial prothrombin, the APTT, to monitor the therapeutic effects or toxicity of heparin. This slide says frequent laboratory monitoring for this bleeding time. But I want to remind you that's only when we use heparin for a therapeutic modality. When we're using it for a prevention modality, we do not need that frequent laboratory monitoring. Such as the next little bullet there, which would be for a catheter flush, which we are keeping like a central line catheter from having any clotting or little thrombi forming at the end. And it even says no monitoring is needed in that case. So at the very top here, the dosage range is very wide for heparin. So I'm not going to ask you to memorize doses, but let's think about and why it's very wide. It goes from 10 units per ml all the way up to 40,000 units per ml. Well, remember, heparin can be used to prevent and it can be used to treat. So when it's used to prevent, we use those smaller dosage in the lower end of the dosage range, which is one of the reasons we don't need the monitoring. When we go to treat something, we're going to use treatment level doses, which are going to approach the 20,000 units and 40,000 units per ml concentrations. And with that much in the therapeutic use, we will absolutely need to monitor their coagulation labs or their bleeding times. So for prevention, most common, it's used to prevent deep vein thrombosis. However, we now have better drugs for that, but let's just stay here with our heparin. And when we use it for prophylaxis, you see it's at 5,000 units, sub-Q 2 or 3 times a day, usually 2 times a day. And at this point, when we're using this amount, we do not need to monitor the APTT. If they're in the hospital and they're already getting their labs drawn every day, we will probably draw their coax and check it anyway. Now, when we use it therapeutically for treatment, we use it as a continuous IV infusion. So here's a hint. If you go into a patient room or you're taking a report and they tell you they're on a heparin drip or you see a heparin drip in their room, this is not prevention. This is therapy. They are having this for a reason. And when they do this, we do have to measure the activated partial prothrombin time, or APTT, probably about every 6 hours until we see the therapeutic effects. And even then, I'm telling you, we're going to watch them closely. And because what can happen is this is a high alert drug, because the biggest problem that could happen is bleeding. And it's not bleeding from like something on their arm where you can hold pressure. The bleeding we worry about is spontaneous bleeding in the brain and in the GI tract, which we don't know is happening until they have symptoms and things are gone really bad. So heparin can be given sub-Q or IM. If you're giving it sub-Q, you're preventing something. I'm sorry, not IM, never IM. If you're giving it sub-Q, you're preventing something. If you're giving it IV, you're treating something. So you want to ensure that you do not give it IM. You need to give it in an area of deep subcutaneous fat. And I think if we all decided to try and find that part on our body that has the most subcutaneous fat, most of us would pick our belly. And that's generally where it is. And heparin is traditionally given in the belly, in the abdomen, because of that. We rotate around the abdomen. So we're not giving it in the exact same spot every time, because they get big bruising and hematomas from that. So we try to avoid the umbilicus by giving 2 inches away from there. If they have an abdominal incision, we like to do it away from the incision, any open wounds, etc., because we don't want to cause that area to have like less platelet activity. When we give these, we don't aspirate with subcutaneous injections anymore anyway, but we always say, don't aspirate And don't massage the injection site because you can cause a hematoma. Now, IV, remember, if you're giving an IV, you're treating something. And again, this is a high alert drug and you're going to be doing concentrations. And we're going to get into that heavy math pretty soon. And you're going to have to be able to calculate how many units they're getting IV per hour based on what the mix is in that bag. So because of this, the doses are checked with another RN. You always want 2 RNs to check your dose. And honestly, a lot of RNs double check their sub-Q doses as well. They can be a bolus infusion, an IV push, or a drip. When you give an IV, your anticoagulant effects are immediate. So just remember, if it's an overdose, you're going to have a problem. And we will at least daily, if not every 6 hours, monitor their coagulation to see if it's therapeutic, or maybe it's a little too therapeutic and we need to dial back on that. If we have too much anticoagulation, protamine sulfate is our antidote for this. The most significant toxic effect with heparin is bleeding. Most of the time, we're worried about the intracranial or intra-GI bleed. But if you start to see hematuria, blood in the urine, melena, blood in the stool, you notice a lot of ecchymosis on your patient's skin, or their gums are bleeding, or a lot of petechiae, what this is telling you that you can actually see, so you're not seeing frank red blood coming out of the patient, but you're seeing subcutaneous bleeding, maybe coming again, well, hematuria would be coming from the GI tract and melena as well. What that indicates to you is that the clotting ability of the blood has been significantly affected. And when we see it like that, we need to stop the infusion and check an APTT. Because if you see petechiae and ecchymosis that didn't happen because they banged themselves and got a bruise, is spontaneous bleeding, there's a chance they could be having spontaneous bleeding in their brain or their gut. And you need to watch their neuro status very, very closely, because subtle changes can indicate a neurobleed. So in this case, you would stop your infusion immediately and do a little bit more assessment, and then determine what the next course of action would be. Again, protamine sulfate is probably what they're going to order. We do also, when we're giving therapeutic heparin, the higher doses continuously, we watch for heparin-induced thrombocytopenia. I don't expect you to differentiate between type 1 and type 2 for one of our tests. I want you to understand that this can be a fatal thing, and what you need to be looking for is watching the labs as they come around. And if you see the platelets starting to drop, then you know the natural ability of the body to clot the platelet, there's something going on. And that's not, heparin is not supposed to affect your platelet count. You still make the same number of platelets, it's in the clotting cascade where heparin works that keeps them from being able to have their coagulation properties. So you shouldn't see a decrease in platelets with somebody who's getting heparin. Well, if you start to see their platelets dropping, there needs to be a conversation happening with their provider. If you see an acute number, like a big change from one day to the next, that's immediate. Stop that heparin and call your provider, because thrombosis can be fatal. That can happen from this thrombocytopenia. So now let's shift over to our low molecular weight heparin, which is heparin's cousin, or stepsister, stepbrother, enoxaparin. And it's a smaller molecule. Remember, heparin's a very large molecule. Well, enoxaparin, or Lovenox, is a smaller molecule, and it has a more predictable anticoagulant response. It hits fewer areas. It's in the cascade, the clotting cascade. It is a more specific area of action, which makes it ideal for post-op prevention of DVTs and things like that. And it helps us because we don't have to do that frequent monitoring that we do with heparin. And we have less of the variability. So we like to use enoxaparin in place of where we used to use a lot of heparin prophylactically. So what are your nursing implications with some of the enoxaparin? I want to point out to you that it comes in a pre-filled syringe. And it's a one-time only use that will get thrown away when you're done. There's always a little air bubble in there, and the manufacturer has different reasons for it being there. But primarily, when you go to give the injection, that air bubble helps to make sure all of the drug is administered. And you never want to expel the air bubble. You want to just go ahead and take the cap off, clean the skin, and give your drug. There's no need to mess around with the syringe unless you have to get out unless your dose is less than what's in the pre-filled syringe. We're going to still give enoxaparin in the abdomen subcutaneously. And the needle on it is very small, so it won't be given IM. Some takeaways for heparin and enoxaparin. They are both high alert medications. You always double check them, but heparin more so, especially IV. Heparin has a wide range of dosing and concentration differences because it has such a different uses, prophylactic versus therapeutic. So always double check what you're giving with another RN. It can be administered sub-Q or IV. If it's IV, they're likely not going to be at home. And actually sub-Q, we don't really send them home on sub-Q heparin anymore. There's two uses: prevention with little to no monitoring, and then there's treatment with close monitoring. Enoxaparin is subcutaneous administration only. We do not give it IV. It comes in a pre-filled syringe. You're going to administer this in the abdomen. You don't need to aspirate or rub the site with either of these drugs. Both drugs, the most significant adverse effect would be bleeding, and we worry the most about internal bleeding, which is bleeding that can occur and have and go on for a long time before we're aware that it's happening, which then can put a patient into risk for hypovolemic shock or even a neurologic event. The reversal antidote for both of these is protamine sulfate if one is needed. All right, now you know everything you need to know about heparin. Happy studying.